Hi, everyone. My name is Nasi, for those that don't already know. And I'm an third year occupational therapy student. It's my final year. And today I'm just coming to do my capstone review about my time here at Jesse Brown VA Medical Center. Just a small introduction into my capstone. So I was here for about 14 weeks, this week being my last. And when Sean and I met, we discussed the issues that the VA has been having with residents putting in a huge magnitude of inappropriate physical therapy and OT consults. And so we were trying to brainstorm how would I be able to assist with that, or in what ways could we work to try to better that, aside from attending interdisciplinary rounds. So, of course, a part of my time here was to attend those rounds daily, but also to create and implement educational lessons. Um, to basically create a curriculum that covered different lessons that hopefully would educate the residents, and therefore hopefully decrease the amount of inappropriate consults that have been put in. As I mentioned before, Sean is one of the mentors that I have during my time here, as well as Dr. Neil. So going right into the interdisciplinary rounds, I would meet with the teams 4 to 5 times a week, meet every day as much as we can. And I met with 3 teams. I met with team 5, 7, and 8. And I also met with the ICU team. However, the ICU team is not a technical part of this, the data that was used to assess change, because as those that do round with ICU can see, that you barely meet with any of the residents that are taking care of the patients on those floors. We would meet for about 10 to 15 minutes. We would review and discuss the patient list in totality. We met with the social work as well. So it would be social work, me and the residents. We would go through the list and discuss all the patients, their discharge dates, their diagnosis, if they needed any services, and just basically to ask any questions that we may have. As well as all of this, when I would attend the rounds, my goal was also to present the educational lessons. That wasn't done immediately off the bat, because I have to obviously create the curriculum for a while and assess the teams and just to see how things were going. But eventually, obviously, I began to present lessons about 2 to 3 times a week with each team. And each team would always cover the same topics throughout the week, whether they were on different days or not. This is just a screenshot of one day of how I recorded the rounds. I would have the patient names, as you can see here, they're blacked out. For patient confidentiality, I also would see if a PT consult was put in, so yes or no. I would put yes, and then highlight it in yellow if it was an inappropriate consult. And then I would put I would do the same thing for OT consult. Then I would put discharge recommendations if it was applicable, and a discharge date as well if it was applicable, and a diagnosis for all patients. And then at the very bottom here, you will see the amount of inappropriate consults put in for the day for the PT versus OT, as well as the total amount of patients throughout that day. My guideline for determining whether a consult was appropriate or inappropriate was fairly simple, in that, I always ask myself this question for every new patient that I would look through. Is there a new functional change that is impacting the patient's ability to participate in ADLs or IDLs, or impacting their mobility? And if there isn't anything changing, if there hasn't been anything that was different from when they've been here before, more than likely, most likely, it always proved to be an inappropriate consult. Obviously, there are more in-depth things that you still are to read throughout the chart. However, the basis, this is always where I began. Is there something changing? Is there something different? Is this something new that is affecting the patient's ability to participate? And then I would go from there. And then right into the curriculums and the lessons. The overall goal of the curriculums and lessons, as I said before, is to create educational information on various health professions. So as I did talk about PT and OT, I also talked about speech, and I also talked about physiatry, because those are other disciplines that the residents are working with as well. And I really wanted this to be an interdisciplinary forum. I wanted to be very discussion based. I didn't just want to be throwing information at the residents, but that way we would be able to understand and explain each other's services. I also made sure that as I was talking about these things with the residents, I wasn't just seeing it as if I was coming to just give information, but also trying to receive information, because I really wanted to know what they do as well. I'm not a medical student, and so obviously my information or my knowledge on what they do is also limited. And so I took it as a moment to learn from them as they would from me, just so that they can feel more obliged and open to doing so. Aside from talking about the various health professions, I also talked about inpatient mobility. I created a therapy consultation tool that I was hoping would guide them through their process in determining whether a consultation would be appropriate or not, in which you will see later in these slides. I also talked about how to navigate CPRS to figure out how to put in the consults, because I found that a lot of residents would just put in PT consults and assume that that also carried over to OT, when it really didn't. And then also to know the difference between requesting an inpatient consult versus them just wanting to put in a consult because someone needed a new wheelchair or someone needs a dressing stick. Then we also talked about justification of services, which is basically, I wanted the residents to go beyond eval and treat. I wanted them to really fully understand what it is that they're putting in the consults in for and why, to justify their reasonings behind doing so. I always told them that put in the reasonings as if the therapist you're sending this to does not work at Jesse Brown and has no access to this charting that we are able to see every day. Because obviously outside of Jesse Brown, that may likely be the case, that they will be giving information, sending referrals out to outside providers. But if a provider just sees evaluate and treat, what are they evaluating and treating? And the person is likely to get denied for such, or insurance just doesn't cover it. So I really wanted them to understand the importance of really justifying the reasons behind why they're saying therapy needs to put it in. And then lastly, I also created case studies so that case studies so that they would be able so that they can have examples and be able to work on determining whether a consult was appropriate or not. So I just made examples of different people, different case studies, and we went through them and determined whether those were appropriate consults or not, just so I could make sure that they fully understood all the information that I had been giving them. And then here is an example of one of the lessons plans that I created that you should have either a hard copy of or an email copy of for yourselves. And this is just to help guide the therapists that will be working with the teams know how to present this information. So as I said, we have the target population because this was mainly created for the residents here at Jesse Brown, and then duration for each lesson. No lesson will be more than 5 minutes because research has just shown the shorter the lesson with more compact information, especially in the medical field, where is the likelihood that information will be retained. The longer it is, residents tend to feel that it's impeding on their time. And therefore it's believed they start to tune out at a certain moment in time. The information just doesn't retain as well. And then I have learning objectives, the goals that are meant to be achieved via the lesson. I have materials, if applicable, to the lesson. It will have an appendix on it, which the following appendix will correspond to the lesson follow after. In some lessons, you will see recommended readings that I suggest will likely help the residents further understand that particular topic that is being touched for the day, if they choose to want to know more about the topic. Then I also created an outline, kind of like a flow that I believed would be helpful to the therapist to know, maybe I'm not exactly sure how I'm going to present this information. And this is just a nice little step-by-step structure of how that can be done. I also created video correspondence to all of the lesson plans, or rather most of the lesson plans, to help just create a verbal and a visual on how this information can be presented. So this lesson was the introduction to the therapy consultation tool that I created. And again, this tool was created to better help the residents have better clinical judgment when they're determining whether a consult is appropriate or not. So this is the tool itself. As you see here in the very beginning, it's asking if the patient is currently at their baseline of functional status. Whether they answer yes or no will determine how they go through the flow chart. The different type of consults here are the OT inpatient consult, PT inpatient consult, the PT and OT mobility and self-care aid consults, as well as restorative nursing consultations, to know that those are things that can be put in and should be put in. And then at the bottom here, you'll also see additional information that is helpful to the residents. These are things that I printed out and gave to them so they could keep. Many of them would just post it on their walls to be used. And I also would mention how this should transcend over to the overnight staff, being that I never meet with the overnight residents. Okay, so basically that was what I did during my time here for the 14 weeks. And then, as I said before, I wanted to see if me meeting with them daily and presenting all this educational information would make any change at all on the residents' decisions or the amount of inappropriate consults that they would put in. And so these are the 3 teams that I worked with, and I compared their first week of their rotation to their last week of their rotation. As you all know, most residents are here for 4 weeks, so I compared week 1 to that of week 4. None of the teams proved to have any statistical significance, as you can see here. However, this is likely due to the very small data that was being compared, being that I was comparing the days or the percentage of week 1 to week 4, which in actuality is just about 4 to 5 days being compared to another 4 to 5 days, which is relatively very small. And being that the residents also may not have a huge magnitude of patients, and that it's not out of just all the patients, it's just out of the new patients that are being presented over time. So some teams ended up with a huge amount of residents, a huge amount of new patients because they were on call that week, and some didn't because they just weren't on call that week. So it really varied on those different factors. However, I was still able to see the amount of inappropriate consults reduce. Seeing that there were 4 being put in 1 week, and we reached down to 0, at least across the board on all teams. We reached 0 by the end of week 4 across the board. So I was able to see that, they are listening to what I'm saying. They are reducing their rates of putting in inappropriate consults, but are putting in as well appropriate consults. So we were able to see that change. So it has proven to be very beneficial to meet with the teams because they do have questions, and they can't, unless we make ourselves readily accessible to them, they generally will not ask those questions. So it's just, and will rather put in the consults to cover their bases. But if we educate them and let them know that you guys have the ability to make these decisions, these appropriate decisions, and you put in the consults, then they will feel confident to do so because we've already given them the information they need to make appropriate clinical judgments. And then lastly, I just, through my time, just wanted to go talk about some recommendations and tips that I felt were beneficial, that I noticed would probably be beneficial with our time with the residents, and then learning the information that we present to them, and hopefully affect influence our consults as well. So I think obviously rounding continuously should continue. We should continue to have IDR rounds. That is a huge influence, beneficial to us as well as beneficial to the residents, as well as beneficial to the social work. So it's a huge interdisciplinary thing that has been beneficial and has continued to shown to be beneficial. And I believe during those rounds, any opportunity for educating the residents, take it. Even outside of the curriculum, outside of the teaching lessons, anytime something comes up, let them know. I would always take that initiative, even if it was just a little tidbit. Oh, I noticed that you did this. Let me tell you how you could do it better. Because they pay a lot more attention than they show. You may not be believed that they are taking in this information, but they definitely are listening. When I saw that my tools were being placed on their walls, I was super shocked because I never thought that was something they were doing, and they would call my attention to it, like, oh, I put that on there. And then at some point, some residents would even ask me, oh, what's our percentage this week? What's our percentage this week? How many inappropriate consults did we have? So really they're paying attention. And it probably also will be good to make that maybe a future incentive, letting residents know that you're tracking their percentages across the board, and hopefully be able to motivate them. Maybe make it a competition across teams. All residents love food, so maybe that would be a great incentive. However, maybe making a competition across the board will really motivate them to do so, because I saw that they were motivated to do so when I would tell them their percentages. And then some other things that I found just helpful for me when looking for information. I know we go into Vista R2 to print out our rounding list. Always look up the residents instead of the attendings, because their attendings are constantly changing. And sometimes there are 2 attending names to a team. And so it's hard when you have to put in 2 attending names, or virtually impossible. I didn't see that I was able to do that. But once I started putting in the seniors' names, all the patients would be able to show up all the time. And it just made it that much more easier. For those that meet with the SICU and the MICU, it's a lot harder to find the teams. And so I was always trying to figure out a new way, or the best way to reach these teams, aside from going on the floor and looking and randomly asking for people, because it just takes up so much time. So I would go into CPRS and I would look up the attending's name at the top, whether it's the attending or the senior, and I would just go into the phone book and I would call the attending that, this person has this consult, or this person could use this consult, or this was the consult that should have been put in. And they were always receptive, and it was super easy to get in touch with them that way. And then I would always ask to, what's your extension? What's the best way I could reach you guys? And they would, obviously tell me. Aside from looking up the resident, you can also find, the surgery attendings or the medical attendings via the notes, which would probably be a little longer, but that's also an alternative if the former doesn't work. I mean, I think the biggest thing for me that made this super possible, or very successful, was creating relationships with my residents. I didn't just go in there wanting to get information, wanting to feed them information, wanting to go through the patient list, but I really would, go in there and ask, how's you guys' day? What do you guys do? Where are you guys from? Where do you live? And also relating things to me and making things personal for myself in all aspects. Because once they're able to do that, they really do care. You guys are spending a month with each other, and it's best to make it's best to take the most out of it. And so really creating that relationship with them, and really letting them know I want to know about you guys, and I want you guys to learn about me. And it just proved to be much more effective that way. It made it easier for me to say, this person needs a consult, put it in for so and so reason, and they would get it, and that would it would be a lot more easier that way. So yeah, these are things that I felt have been effective. This has been the overall overview of my project. Thank you all for allowing me to be here and spend this time here. It has definitely been great. And thank you for listening, or rather watching.